those of us who do interventions on branches of the aorta know that it's very difficult to monitor those reconstructions afterwards. The typical vascular lab criteria we use to evaluate the native arteries don't seem to hold up after you've done a bypass or put a stent in the aortic branches. So Nasim Hedayati, another member of our vascular surgery faculty, is going to discuss some ways to try to solve the surveillance after aortic branch reconstruction. Nasim.
Good morning. Thank you for being here. I know I'm the only person standing between you guys and snowing downhill with Dan Link, so hopefully this won't take very long. When I was asked to give this talk, I kind of thought about what can I possibly talk about. Hopefully some of this is not redundant, and hopefully you guys will learn something. I have no disclosures. As you probably all know, there's guidelines that the American College of Cardiology and American Heart Associations have put out in terms of recommendations of when we start out looking at people with things like renal artery stenosis or chronic mesenteric ischemia. And one of the easiest and cheapest ways to do that is with duplex ultrasonography, and this sort of leads to what I'm going to talk about in terms of following patients up after they've had some form of intervention. So you may already know this, but Medicare puts out quite a bit of data about what we're doing out there. In 2000, there were about 21,000 claims for renal artery interventions. This was up from 1996, where we only did about 13,000. This was an overall increase of 60%. Surgery for renal arteries went down by 45%, but the percutaneous endovascular procedures increased by almost 240%. So what does that all mean? What do we do in terms of follow-up for our patients? There's really no set guidelines. I think the majority of places have their own guidelines in terms of what we do and how we follow our patients. Typically at our institution, we follow our patients a month out after their interventions. Usually, again, another ultrasound 3 to 6 months, and then another ultrasound at 12 months or earlier if it's clinically indicated. But in terms of guidelines from criteria standpoint and velocities that we use for native vessels, there are really no established guidance on what we should be using. So this is what we typically use for just native renal arteries. The two main things we look at are the peak systolic velocities and the renal aortic ratios. And this is how we determine the degree of stenosis in the renal arteries. And as we know, we just talked about, the number of renal artery angioplasty and stentings have gone up tremendously. And they're quite successful. The success of stenting renal arteries is up to almost 98%. That's compared to what was reported with just angioplasty alone. The restenosis rates are a little bit different, 17% for stents and about 26% for angioplasty. Restenosis for free survival is 50% at 12 months for these patients, 40% at 18 months. Complication rates, now if you look at some of the earlier literature, I think people talked about mismatch of stent, vessel size, but I think we have better technology and we have better ways of trying to make sure that some of those that happened on earlier with probably a lower learning curve don't happen, but we still have access artery procedure-related complications, bleeding, dissection, and so forth. So here's just an image of an ultrasound image actually for this one. If I can use this pointer, you can actually, a lot of times you're unable to really see the stent, but here you do see the stent wall. And this is the velocities that we got through this stent wall. You see that the peak systolic velocity for the stent is actually 510. So what do we use and what guidelines do we use? She and colleagues looked at 67 patients. They had two groups in this patient, specifically looking at in-stent restenosis. They chose two groups. One was the group that had been stented, and one was a group that had not been stented. But both groups had at least 50% angiographic evidence of stenosis in the renal arteries. And what they found is that in this group that had at least 50% stenosis in the renal arteries, in group 1, which was the stented group, the mean peak systolic velocity was 450, compared to group 2, which had no stent, and the mean systolic velocity was about 360. As you can see, there was also a difference in the renal aortic ratios of about 6 in the stented group and about 4.9 in the non-stented group. So what they found, this group found that if they chose a peak systolic velocity of 395, they were able to have a sensitivity of about 83% and a specificity of 88%, that's pretty good, to predict a 70% in-stent restenosis in their group. A renal aortic ratio of 5.1 also yielded a 94% sensitivity and 86% in trying to predict in their group of patients at least a 70% in-stent restenosis. So is there a consensus? And unfortunately, no. I think the majority of studies that we see are small institutional series, and the data really has been kind of all over the place. There's some earlier studies that had used other velocities, such as 226, that even lowered the renal aortic ratios to predict in-stent restenosis. But currently, as it stands, unfortunately, we do not have guidelines, but we all know that probably a higher velocity is probably what we should be using other than the native vessels. So as Dr. Laird and others have just recently spoken about, sort of the increased use of fenestrated graft in our country and elsewhere, there was a group out of the Cleveland Clinic that actually looked at the renal arteries that were stented with these fenestrated grafts, specifically looking at the reintervention rates and also predicting stenosis. Now, granted, the majority of these obviously are done not necessarily for stenosis in the renal arteries, but because they're treating aneurysms. They found that they had, out of this group of patients on 518 renal arteries that were intervened on, there was a 20% secondary intervention rate. They used a peak systolic velocity of 280 to be able to detect at least a 60% stenosis in the stents with a sensitivity of 93% and a specificity of 100%. And the renal aortic ratios were about 4.5. So now moving on to mesenteric artery stenosis, again, we have criteria that we use for the SMA and the celiac in order to predict the stenosis in those vessels. But really, we have no established guidelines for stents. Here's just a case that I put up here for just demonstrations. There's an occluded celiac artery. There's an SMA with near occlusion, which was successfully stented. The patient did great. So on follow-up, this is a 3 months ultrasound. You can see the SMA that's been patent in the patient is asymptomatic. The velocity is about 300. We move forward to a year from the intervention itself, and now we see that the velocity is 522, or 502, I'm sorry. So what do we use? And unfortunately, there's not a lot of data as opposed to the renal arteries. That there's quite a bit of papers that are out there in terms of renal artery stents. There's not a lot of data for mesenteric interventions and follow-ups with Duplex. So in general, we know that primary patency of mesenteric stents are about 60–70%. Primary assisted patencies are a bit higher. Patients do have symptomatic relief, and about 75% of them will be symptom-free at a year. The overall morbidity, again, it's related to the access site. It's related to vessel thrombosis, possible bowel infarction. You can see that 30-day mortality can still be quite high in this group of patients. The in-stent restenosis rates have been, in the literature, have been anywhere between 11 to 40% almost. There's a group out of Oregon that looked at 35 patients who had 70% stenosis in the SMA that were treated with angioplasty and stenting. This group's pre-intervention pressure gradients were about 57, and their mean systolic velocities were about 450. So the immediate post-angiographic images showed that the stenosis was less than 30%, so these were considered a success from the standpoint of endovascular intervention. So when they followed these patients, and immediately after the intervention, they saw that the mean pressure gradient certainly dropped to about 10 in this group. But what they found in terms of the ultrasound follow-up, the immediate ultrasound follow-up, was that even though the peak systolic velocities did decrease in all the patients, the velocity still exceeded what we typically use for native vessels. On average, the mean velocity for these were 336. And you can see that on this, that the majority of them, even though they were stented, angiography less than 30%, and had the mean pressure gradients that were less than 10, their velocities on average were still about 300. So again, this goes back to what we do as in terms of follow-up for our patients, the immediate ultrasound and then the ultrasounds at 3 months and 6 months and 12 months. But the more important thing is there some way that we can try to reestablish guidelines for stented vessels? And that's probably a little bit hard. We know that there's some non-physiologic stress that's caused by the stents on the changes on the arterial wall. There's elements of compliance mismatch between the artery and the stent itself. And probably that stress in that artery is kind of dependent on the type of stent we use and also the plaque that's in the artery itself. There's a bit more data in the carotid stent ultrasound criteria. We know that in carotid arteries, like for instance the closed stents tend to have higher velocities than the open cell stents. So I think we all recognize that we're going to have to use higher velocity criteria than would we normally use for native vessels in trying to predict in-stent restenosis. And the importance of follow-up, obviously, with duplex ultrasound and also following closely the patients and their clinical status is important. Currently, at UC Davis, we're trying to look into that. Dr. Aaron Baker, who's one of our residents, is looking at all our data with renal and mesenteric artery stenting, and we have a student, Victoria Chu, who's also looking at that, hoping to see if we can establish some criteria for our own lab in terms of what velocities we should use, in terms of when we should intervene on these patients. When is a velocity increase significant enough for us to do potentially another intervention on the patient? Thank you.